Picture yourself at 74, you feel well, you are sleeping reasonably, your energy is decent, you are doing the things you enjoy, you go in for a routine annual physical, nothing specific is bothering you, your doctor glances at the chart and says, let's run a few tests just to be safe. 6 weeks later you are sitting in a surgeon's office, not because something was wrong with you when you walked in, because those just to be safe tests found something, and that something set off a sequence of events that your body at 74 was not equipped to handle without consequence. That sequence plays out more often than the medical system openly acknowledges, and the data behind it deserves an honest conversation that a 15-minute appointment almost never makes room for. If this channel has ever given you something worth knowing, hit that subscribe button right now, leave a like, and drop a comment below. Because that is what keeps this kind of conversation reaching the people who genuinely need it. I'm Dr. Mercer, and this channel exists to bring you the latest evidence-based research on senior health, simplified and designed for adults over 60. Stay with me through this entire video, because by the end you will have 5 specific questions that will change the dynamic of every medical conversation you have from this point forward, and a clear understanding of which 5 routine screenings carry the most significant risk-benefit shift after 70. Let's begin with the concept that makes everything else in this video make sense. I call it the longevity lens, and it describes something fundamental about how preventive medicine works differently after 70. When you are 50, screening medicine works beautifully. You find a problem early, you treat it, and you potentially protect 30 or more years of healthy life ahead. The investment is proportionate. But after 70, 3 things change simultaneously. First, many conditions detected by routine screening in older adults will never actually cause harm. They grow slowly, they cause no symptoms, and in a significant number of cases, the individual would outlive them entirely. But once a finding appears on a report, medicine does not have a leave it alone button, it has a treatment button. Second, your body's tolerance for intervention changes with age. A procedure that a 55-year-old recovers from in 2 weeks may mean months of complications, loss of independence, or worse for a 78-year-old with multiple existing conditions. Third, there is the cascade effect. One test finds a small abnormality that triggers a follow-up scan, the scan leads to a biopsy, the biopsy leads to a procedure, the procedure causes a complication, and a person who walked in feeling perfectly well is now navigating a medical crisis that began with a test they did not actually need. A study published in JAMA Internal Medicine examining overdiagnosis rates in older adults found that a substantial proportion of cancer diagnoses made through routine screening in patients over 75 were clinically insignificant, meaning the detected condition had no realistic probability of causing death or symptoms before the patient would have died of other causes, yet the treatment cascade that followed produced measurable harm in a significant number of those patients. The math changes after 70. Nobody is doing that calculation with you in the room. Let me now walk you through the 5 screenings where this shift is most significant, starting with the one whose risks the medical system most consistently underestimates. The first is routine colonoscopy after the age of 75 in adults who have had regular prior screenings with clean results and no current symptoms. The United States Preventive Services Task Force, the body that sets the primary screening guidelines for this, explicitly recommends against routine colonoscopy for average-risk adults over 75. The evidence is direct. After that age, in a patient with no symptoms, no family history, and previously clean colonoscopies, the risk of the procedure outweighs the realistic benefit of early detection. Those risks are not theoretical. Bowel perforation, a tear in the colon wall, occurs in approximately 1 in every 500 procedures. In a younger adult, that is a serious but manageable complication. In a 77-year-old with any cardiac, renal, or respiratory condition, it can mean emergency surgery, extended hospitalization, and a recovery that permanently changes daily function. The bowel preparation required the night before is itself a risk in older adults. Severe dehydration from the prep solution can trigger cardiac arrhythmias, kidney stress, and electrolyte imbalances that become medical emergencies before the procedure even begins. I had a patient I will call Dorothy. She was 77, had had 2 clean colonoscopies in her 50s and 60s, no polyps, no family history, no symptoms. She was referred for another as part of a standard scheduling protocol. She was concerned but did not want to seem difficult. She went. The preparation caused severe dehydration overnight. her daughter brought her to the emergency department the following morning before the procedure could be performed. She spent 4 days in hospital with electrolyte abnormalities that placed her heart under significant stress. She never had the colonoscopy, and the clinical reality was that she did not need it. If you have no symptoms and your previous scopes have been clear, ask your physician specifically whether continued routine screening remains appropriate for your age and individual risk profile, and ask whether a non-invasive stool-based test could serve as an alternative. The second screening is aggressive cancer screening in average-risk older adults, specifically PSA testing for prostate cancer in men over 70 and routine mammography in women over 75 without specific elevated risk factors. I want to be precise here because this is a topic that deserves nuance. Cancer screening has saved millions of lives and it can save yours. What the data shows is that after 75, routine screening in average-risk asymptomatic individuals has a serious overdiagnosis problem, and overdiagnosis leads directly to overtreatment. Overdiagnosis means that the imaging technology now available is sensitive enough to detect cancers that are, biologically speaking, barely active, tiny, slow-growing tumors that, left alone, would never spread, never produce a symptom, and never shorten a person's life. You would die with them rather than from them. But the moment the word malignancy appears on a report, the clinical process activates regardless of whether the cancer poses an actual threat. A study published in the New England Journal of Medicine found that a substantial proportion of cancers detected through mammography in women over 70 were clinically insignificant, meaning that treatment offered no survival benefit but produced side effects and procedural risks that measurably reduced quality of life. I had a patient I will call Richard. He was 79, retired, still active, still fishing on weekends. His PSA came back slightly elevated at a routine check. A biopsy confirmed low-grade, slow-moving prostate cancer. His urologist recommended radiation. He trusted the recommendation and completed treatment. Within a year he was managing chronic fatigue, urinary complications, and a daily quality of life that had declined substantially. His cancer was, by clinical classification, the kind of man his age would almost certainly have lived alongside rather than died from. The knowledge of that, had it come before the treatment decision, might have led to a very different choice. The question worth asking before any cancer screening after 70 is this: if this test finds something, what are the realistic treatment options for someone my age and current health status? And is that treatment likely to extend my life or primarily introduce new complications? That one question frequently transforms the conversation entirely. The third screening is routine cardiac stress testing in patients with no cardiac symptoms. This one surprises people because it sounds so clinically responsible. Your doctor proposes checking that your heart is functioning well, you get on a treadmill, or receive medication that temporarily stresses the heart while monitoring proceeds. Here is what the data shows about this in practice. False positive rates for cardiac stress testing in asymptomatic adults over 70 can approach 40% or higher in certain populations. Nearly half the time, the test identifies something that looks like a problem when the heart is actually functioning well, but an abnormal finding cannot be left unaddressed. A cardiac catheterization is scheduled. A catheter is threaded through the arterial system into the heart for a direct look. This procedure carries real risks including arterial injury, arrhythmia, and kidney damage from contrast dye, all meaningfully higher in older patients. And when catheterization finds a partial blockage, which is extremely common in adults over 70 regardless of whether they have symptoms, a stent may be recommended. Multiple landmark trials including the ischemia trial, one of the most comprehensive in this area, found that in patients with stable coronary artery disease without significant symptoms, stenting did not reduce the risk of heart attack or extend life compared to optimized medication and lifestyle management alone. The procedure did not outperform the pills, but it carried its own procedural risks and then a lifetime of blood thinners with their own bleeding complications. You can go from feeling entirely well to a routine test flagging something, to catheterization, to stent, to ongoing medication, and be statistically no better off than someone who managed the same finding with medication, daily movement, and blood pressure control. If you have no chest pain during exertion, no unexplained breathlessness, no dizziness during normal activity, ask your physician specifically why the stress test is being proposed and what the clinical plan would be if an abnormality were found. The fourth screening is bone density scanning, followed by automatic long-term medication in patients over 75 without prior fractures. Osteoporosis is real, and hip fractures in older adults carry serious consequences. I am not questioning the importance of addressing bone health. I am questioning the automatic prescription of bisphosphonate medications that frequently follows a DEXA scan result in older adults whose individual risk profile has not been carefully evaluated. Long-term bisphosphonate use has been associated with osteonecrosis of the jaw, a difficult-to-treat deterioration of the jaw bone, and with atypical femoral fractures, spontaneous stress fractures in the thigh bone that require surgery and that occur paradoxically because normal bone remodeling has been suppressed. The single most evidence-supported intervention for preventing fractures in older adults is not pharmacological, it is fall prevention. Research has shown that structured balance training, including programs like Tai Chi, reduces fall risk by approximately 40 to 50%. The combination of removing trip hazards from the home, installing grab bars, reviewing medications that cause dizziness, getting vision checked regularly, and ensuring adequate vitamin D and dietary protein reduces fracture risk more meaningfully than most medications and with no side effect profile. For patients who have had prior fractures, who have very low bone density scores, or who have specific documented risk factors, bisphosphonate therapy may be clearly appropriate. But for an active older adult who has never fractured a bone, the conversation deserves to start with fall prevention rather than ending with a prescription. Before I give you the action steps, I need to say something clearly. Nothing in this video is a reason to cancel a scheduled appointment, decline a test your physician has recommended based on current symptoms, or stop any medication without discussion. The 5 screenings described here are being addressed specifically in the context of routine asymptomatic screening ordered primarily by age or schedule rather than by a specific clinical concern. Symptoms change the entire calculation. Any new or unexplained symptom, including changes in bowel habit, new neurological symptoms, chest discomfort during activity, vision disturbances, or sudden severe headache, requires prompt medical evaluation regardless of age. The information in this video is the basis for a better conversation with your physician, not a substitute for clinical care. The 5th screening is carotid artery ultrasound in patients with no neurological symptoms. This is the one that receives the least attention in standard conversations about overscreening, and it may carry the most serious consequences of any on this list. A carotid ultrasound checks the blood vessels in the neck that supply the brain for signs of narrowing or blockage. The problem is what follows when a finding is made in someone who had no symptoms. The surgical procedure used to address a carotid blockage, called carotid endarterectomy, carries a stroke risk during or immediately following the procedure of 2 to 3% in standard surgical populations, and higher in older patients with additional health conditions. The United States Preventive Services Task Force explicitly recommends against routine carotid ultrasound screening in adults with no neurological symptoms, no history of transient ischemic attack, no vision disturbances, no sudden weakness or speech changes. Their analysis found that in asymptomatic patients, the risk of surgical harm from treatment outweighs the benefit of detecting a blockage that was not producing any symptoms. Many people over 70 have some degree of narrowing in their carotid arteries. That narrowing has often been stable and silent for years. When it is found through routine screening, a well-intentioned surgeon may recommend repair, but the procedure to address a blockage that was never causing symptoms can dislodge a small piece of plaque that travels to the brain and causes the stroke it was intended to prevent. The far better investment for stroke prevention is managing the modifiable risk factors that drive actual stroke risk: blood pressure, which is the single largest driver, blood sugar, smoking, atrial fibrillation, and physical activity. If you do have any neurological symptom, even a brief one that resolved within minutes, seek evaluation immediately. That changes everything about the clinical picture. Now, here is what to do with what you have just heard. Step 1. Before your next scheduled screening, write down whether it is being proposed in response to a specific symptom you have reported or as a routine age-based protocol. That single distinction matters to every subsequent decision. Step 2. At your appointment, ask your physician what the false positive rate of the proposed test is in patients your age, and what the clinical plan would be if the test returns an abnormal result. Step 3. Ask your physician specifically what the procedural risks of any likely follow-up intervention would be, and request that those risks be expressed relative to your age and current health status rather than as a general population average. Step 4. Ask whether watchful waiting with regular monitoring is a clinically reasonable alternative for your specific situation, and what evidence supports or argues against that choice. Step 5. Ask your physician what the most effective non-procedural intervention is for the condition the screening is designed to address, because very often, as with bone health, cardiac health, and stroke prevention, lifestyle and medication management outperform procedural intervention with substantially less risk. One final clarification before we close: all 5 screenings discussed in this video have clear clinical value in specific circumstances. Colonoscopy is appropriate for anyone experiencing symptoms, PSA testing and mammography are appropriate for patients with elevated individual risk or those who are fully informed and choose to proceed. Cardiac stress testing is appropriate when symptoms suggest a cardiac problem. Bone density scanning is appropriate for monitoring known osteoporosis and guiding treatment in appropriate patients, and carotid ultrasound is appropriate for patients who have had neurological symptoms. The concern expressed here is specifically about applying these tests routinely to asymptomatic older adults based on age and scheduling rather than on individual clinical evaluation. After 70, the goal of your healthcare should not be to generate findings, it should be to protect the quality and independence of the life you are living. You have the right to know what a test is looking for, you have the right to know what happens if something is found, and you have the right to ask whether a treatment for that finding would genuinely improve your life or introduce risks that outweigh its benefit. If this video gave you something useful, hit the like button right now, leave a comment telling me whether you have ever experienced the cascade effect from a routine screening and what you would ask differently at your next appointment. And share this with someone you care about who is over 70 and approaching a routine test without knowing they have the right to ask these questions. Subscribe if you have not already, and I will see you in the next one. Take good care of yourselves.